Hey everyone, welcome, all you future pediatric nurses. Seriously, go ahead and push that textbook aside for a bit. We're going to turn this study session into something way more real, like a clinical shift. We'll walk through the exact kinds of high-yield scenarios you absolutely need to nail for your board exams. So, you ready to clock in for your shift? Because we're about to dive headfirst into some classic PEDS cases. These are specifically designed to sharpen that clinical judgment of yours and get your brain fired up and ready for test day. All right, so here's our game plan for today. First up, we're hitting the triage bay to talk about respiratory and shock. Then, we'll move on to managing some pretty complex cases. After that, we're going to double-check some common medication safety traps. You know, the ones they love to ask about. We'll also cover how to recognize maltreatment, which is so important. And we'll wrap it all up with a final checklist for you to take into your exam. Think of each of these as a critical learning station on our shift. Okay, let's get started. Your first patient is rolling in right now. You know how it is in an emergency. That clock is just ticking away. And what you do first, well, that's everything. So we are going to nail down our priorities using the absolute foundation of emergency care. Airway, breathing, and circulation. Your ABCs. All right, team, listen up. Here's the situation. We've got an adolescent who just came in from a car crash. They're telling you they have sharp chest pain. You look at their respirations, they're fast and shallow. And when you listen, yeah, you hear diminished breath sounds on the left side. So what's that little alarm bell going off in your head right now? What's the first thing you're thinking? And this is exactly how the boards will try to trip you up. See, it's not just about getting the diagnosis right. It's about what you do. You're thinking, okay, this looks like a pneumothorax. You're seeing those signs of hypoxia starting to creep in. So what is your absolute number one immediate priority? What do you do first? Okay, here's the answer. You've got to deal with that hypoxia like right now. Go back to your ABCs, airway, breathing, circulation. Breathing is the problem here, so that's where you act. You apply supplemental oxygen. That is priority number one. After you do that, then you can get ready for the big fix, which is the chest tube. But oxygen first, always. All right, let's move on to another classic high-stakes airway emergency. You have a school-age child presenting with all the signs of epiglottitis. I mean, that inflamed tissue is literally threatening to swell shut and close off their airway entirely. You have to be so careful here. This is an incredibly fragile situation. And here it is, another classic testing trap. Of course, your priority is to watch that oxygen saturation like a hawk. But what you don't do is just as important. You never ever try to get a throat culture. Don't even think about putting a tongue depressor in there. Why? Because any little irritation could trigger a complete laryngospasm and just slam that airway shut. Your job is to keep them calm and let them sit upright, whatever position is most comfortable for them to breathe. So you've done it. You've stabilized the airway and the breathing. A and B are handled. Now we're moving on to C, circulation. You're looking at your patient and you're seeing those early signs of shock. What you do next is absolutely critical for making sure their vital organs are getting the blood they need. And the answer is always get IV access. Before you can give fluids, before you can even think about vasopressors, you have to have a line in. It's the pipeline for everything else you need to do. It's a foundational step you just can't skip. Okay, let's change gears a bit. We're leaving the chaos of the ER and heading up to the floor. This brings us to our second big topic, managing complex cases. And what we're really going to focus on here is the difference between what's anticipated and what's absolutely contraindicated. So imagine this, a classic floor scenario. You get a toddler with a known history of hemophilia who comes in after a fall. You look at his left knee and it's blown up. It's swollen, bruised, and he's clearly in a lot of pain. What you're seeing is a classic acute bleed into the joint, what we call hemarthrosis. So what are your priorities? You got to think sequentially here. Step 1, and this is the most important, stop the bleeding. That means giving them their clotting factor, which in this case is factor 8. Once that's infusing, you move to step 2, managing the symptoms. And that's your classic RICE, rest, ice, and elevation. Plus, of course, getting their pain under control, maybe with some morphines. And here comes the big flashing red light, the major testing trap. In that acute phase, we're talking the first 48 hours, you never, and I mean never, perform passive range of motion on that joint. Why not? Because you could easily dislodge that delicate little clot that's just starting to form and you'll make the bleed so much worse. This is a huge patient safety issue, and you can bet you'll be tested on it.
Okay, pop quiz time. Quick prioritization check. You've got 4 patients calling for you, but one of them is a school-aged kid with sickle cell anemia who is suddenly saying their vision is getting blurry. Who are you running to first? Yeah, it's the sickle cell patient, no question about it. Those vision changes can be a sign of a vaso-occlusive crisis happening right in the eye. That's a medical emergency, people. It could lead to permanent blindness if you don't act fast.
All right, let's head over to the med room for our third section, medication safety traps. We all know the 5 rights of MedAdmin by heart, right? But Pediatrics, PEDs, throws some extra curveballs at you, and we need to be ready for them. This is so important because it's all about what you teach the parents, and you know the boards love to test that. Let's take Digoxin. You have to tell parents to brush their child's teeth after they give it, because that syrup is sugary and can cause cavities. But here's the critical part. You have to stress that they should never double up on a missed dose, and they should not give another dose if the child vomits. The risk of Digoxin toxicity is just too high. Okay, here are some more rapid-fire safety checks you just have to know. Nystatin, you gotta shake that suspension really well before you give it. Ferrous sulfate, give it with some orange juice to help with absorption, and always use a straw to keep it from staining their teeth. And of course, immunizations. Always check those allergies. If a kid has a history of anaphylaxis to neomycin, that's a hard stop, a contraindication for the MMR vaccine. Okay, moving on to our 4th section. This is a really serious but incredibly vital topic, recognizing maltreatment. As a nurse, your assessment skills are often the #1 line of defense for these vulnerable kids. It's all about being able to recognize patterns that just don't add up. So the real key here is looking for things that just don't fit the story. A classic tragic example is symmetric burns. Think about a sock-like or glove-like burn pattern on both feet or hands. That's not an accident from a quick splash. That is highly suggestive of a deliberate immersion injury. And when you see something like that, especially if it's combined with other things like poor hygiene, stories that keep changing, or a child who's failing to thrive, you've got multiple red flags. And that means you're legally obligated to make a report. All right, team, our shift is almost over. Let's pull together for one final huddle. We're going to go over our last section, your final checklist. Think of these as the core principles you need to stuff in your pocket and carry with you on Test It. Principle number 1. Remember that very first patient we talked about? When you're looking at a question on the exam and you're feeling overwhelmed by all the details, just stop, take a breath, and default to your training. Always start with the ABCs. It's your compass. It will guide you to the right first action, every single time. And principle number 2, think back to our hemophilia and epiglottitis cases. The boards are tricky. They won't just ask you what you should do, they're going to test your ability to prevent harm. Knowing what not to do is just as important, if not more so. Honestly, that's the hallmark of a truly safe and competent nurse. And that's it. Your shift is over. Look at what we did. You triaged emergencies, you managed complex patients, and we reviewed some absolutely critical safety principles. The knowledge is in there, you've got it. So take these concepts, walk into that exam room with your head held high, and show them what you know. You are so ready for this. You've got this.